Hello, my name is Sahakian. I'm the Director of Clinical Gastroenterology and Endoscopy at the University of Southern California. First of all, I'd like to thank the course directors, Asadur Çekmeceyan and Avet Petrosyan, for the kind invitation to speak at this conference. Today I'll be speaking about getting started with ESD in your practice. My disclosures. I'll first start with an introduction to ESD and then move on to some of the challenges with ESD. I'll talk about the equipment that we need to perform ESD, the indications and outcomes for colorectal ESD. We'll talk about training, as well as some tips and tricks for performing ESD. First of all, it's important to understand the difference between EMR and ESD. EMR is endoscopic mucosal resection and usually involves removing a lesion using a snare loop using a submucosal injection of fluid. This is very useful for en-bloc resection of small superficial lesions. However, when lesions are larger, they tend to require piecemeal resection if removed with EMR. There are multiple different techniques for EMR. ESD stands for endoscopic submucosal dissection and involves submucosal injection of fluid and dissection using specialized electrosurgical knives. This is very useful for en-bloc resection of superficial lesions of any size in the GI tract. EMR can be performed by several different techniques. The typical technique used in the colon involves injection of submucosal fluid underneath the lesion to elevate the lesion, and then removal of the lesion using a snare loop and cautery. There are different variations of this technique as well, such as underwater EMR or cold EMR. In the upper GI tract, other techniques can also be used, such as cap and snare EMR or band ligation EMR. ESD differs from EMR in that the endoscopist determines the resection margins, whereas in EMR, those margins are generally determined by the size of the snare. Markings are often made to delineate the boundaries of the lesion. Again, submucosal fluid is injected underneath the lesion, and dissection is performed in order to remove the lesion in one piece. There are two main goals of performing ESD. The first is accurate histological staging of the lesion, and the second goal is curative endoscopic resection of the lesion. There are several requirements for performance of successful ESD. The first is that the tumor should be localized and superficial. This generally means that it should be involving the mucosal layer of the GI tract. However, in some cases, involvement of the superficial submucosa may also be acceptable. There should be no lymph node metastases and no signs of lymphovascular invasion. The histological type should also generally be well differentiated. ESD does have several advantages over EMR. EMR is useful for smaller lesions, generally smaller than 2 centimeters. However, for larger lesions, piecemeal resection may be necessary. ESD can be performed for lesions of any size and can have a very high rate of en-bloc resection, lower rates of recurrence compared to EMR, as well as accurate assessment of the margins of the lesion. This can be very useful when dealing with invasive cancer. However, there are also several disadvantages of ESD. ESD is a procedure that can take a considerable amount of time. In the United States, there is still a lack of reimbursement for ESD. The complication rate tends to be higher compared to EMR. It is technically very challenging and also involves considerable training, both observation of procedures as well as performance of procedures on live animal models. Here we see a large laterally spreading lesion in the rectum. This is a pair 0 to a lesion with sessile components. It is granular, and initial biopsies showed high-grade dysplasia. The concern here was that there would be a very high likelihood of recurrence of this lesion if removed with piecemeal EMR, as well as a likelihood of finding underlying invasive carcinoma once the complete lesion was removed. The decision was made to remove this lesion with ESD rather than piecemeal EMR. We can see here that the entire lesion was removed in en bloc fashion, and the final histology did show foci of intramucosal carcinoma. This was considered a curative resection. It was also notable that this lesion came down to the anal verge, and ESD can be very useful in such situations. So we will look at another case of rectal ESD here. This is a 58-year-old male who undergoes a routine screening colonoscopy. He is found to have a 3-centimeter sessile polyp found in the rectum. Biopsy shows tubulovillus adenoma with high-grade dysplasia. The patient is referred for endoscopic resection. Rectal EUS is performed, and involvement of the lesion is found to be limited to the mucosa. The decision is made to perform ESD to remove this. Here we have a Paris 02A plus 1S lesion. This means that it has a flat component with a sessile nodule. Using NBI, we can look at the pit pattern. We see it has a very regular pit pattern, and we don't see any obvious signs of invasive malignancy. We are now performing a submucosal injection. We use a colloid fluid, which allows for a sustained submucosal lift. Here we are starting our circumferential incision. We are using a needle type knife here, which is very versatile. This particular knife can come in different sizes, and it allows for submucosal injection of fluid through the tip of the knife, which allows for the procedure to be performed more quickly and obviates the need for frequent needle exchanges. So here we are continuing to dissect the submucosa, and what we can see here is that we are starting to encounter some submucosal fibrosis, which is fairly common when dealing with colorectal polyps, especially when we have polyps with high-grade changes such as tubulovillus adenomas or polyps with high-grade dysplasia or cancer. In order to make this procedure more efficient and make it easier to cut the tissue, in the setting of fibrosis, what we can do is apply traction. And that's what we've done here using a device attached with a clip from the distal end of the polyp to the opposite side of the colonic wall. And that provides for significant traction, as you can see here. And once we have traction, that can make the cutting much quicker and more efficient in the setting of significant fibrosis. And you can see that here, where we can move much, much more quickly as we are getting traction from this device. And then we can very rapidly go ahead and complete the ESD procedure. There are many different types of knives we can use during ESD. We see that the most commonly types of knives that are used are the needle type knives that we see here. These knives are very versatile. They can be used for circumferential incision as well as submucosal dissection. And often they allow you to inject through the tip of the knife, which can also be very useful and time-saving. We also see knives that have a ceramic ball tip, and these knives can also be very useful and safe because they have this ball tip that can prevent perforation at the muscle layer. They do have the disadvantage that you generally cannot inject fluid through them. The triangle tip knife is also used probably more frequently for the POEM procedure, but it is useful in that it has this triangle tip that can allow you to hook the tissue to more easily cut, especially if you're trying to cut muscle, which you would do during something like a POEM procedure. There are also knives that have a scissor-like function, and these can also be useful for submucosal dissection, especially in situations where there is significant vascularity, as you can coagulate and cut at the same time. These knives often are also used for Zenker's diverticulotomy. A clear distal attachment or cap is also very useful for performing ESD for several different reasons. First of all, it can give you significant traction, which allows cutting to happen more easily, and also can help with tamponade and control of bleeding, as well as stabilization of the endoscope tip. There are different types of caps that can be used. Often these tapered type caps are very useful as they allow the endoscope to get into smaller areas. Hemostatic forceps are crucial for performing ESD and allow for adequate hemostasis in the setting of significant arterial bleeds. This is very useful rather than trying to use a clip, which could potentially obstruct the view and make it more difficult to continue on with the ESD procedure. The use of CO2 insufflation is also essential for performing ESD. These can be very long procedures, and CO2 allows for patient comfort during the procedure. There is also a risk of perforation when performing ESD. If a small perforation occurs, if CO2 is being used, the dissection can be continued and the perforation can be repaired with clips, allowing for continued dissection. However, there is a concern that if air insufflation is used and there's a small perforation, that could quickly result in a significant pneumoperitoneum. Why would we want to perform ESD in the colon? Well, we know that for larger lesions, such as lesions above 2 centimeters, en bloc EMR will often fail in over 43% of those cases. We also know that when piecemeal resection is performed, there is a significant recurrence rate of about 10 to 20%. If piecemeal resection is performed of an invasive cancer, that patient still may require a formal surgical resection, as the margins cannot adequately be evaluated. ESD should be considered in several different situations. When the lesion is very complex and snare resection is difficult, for example, when partial snare resection has been performed previously, when we suspect cancer and we would like to have en bloc resection, this gives us accurate pathological assessments and potentially an endoscopic curative resection. And also when we have significant fibrosis that would make EMR very challenging, or residual or recurrent adenomatous lesions. There has been a large meta-analysis of 8 studies that compared ESD to EMR in the colon. What they found was that in the ESD group, there was a much higher rate of en bloc resection, and the rate of recurrence was also, as expected, lower in the ESD group. However, the drawbacks of ESD were that the procedure time was higher. There was a higher rate of additional surgery in the ESD group, and this was thought to be because there were more cases of submucosally invasive cancer that later required surgical resection, as well as the rate of perforation that was also higher in the ESD group. We can see the outcomes of colorectal ESD here from several different studies. You can see that there are over 1,000 lesions represented here amongst these studies. And we can see that the rate of en bloc resection is very, very high, between about 80 to 90%. And we see a relatively low rate of bleeding, a very, very low rate of recurrence. However, we do see modest rates of perforation ranging anywhere from about 3% to 9%, keeping in mind that these tend to be small perforations and generally do not require surgery and can be usually repaired easily with clips. Training in ESD can be challenging as this procedure is not performed at every training program. In Asia, an apprenticeship model is used where didactic education is given and observation of many cases. The trainee then will perform ESD on animal models and will assist the expert endoscopist in performing ESDs. The trainee will then start performing procedures with assistance of the mentor, and will generally start with procedures in the distal stomach, then move on to the esophagus and the more proximal stomach and rectum, and later then move on to lesions in the colon, which tend to be more challenging. There is a higher prevalence of gastric cancer in Asia, which tends to make it easier to train due to the volume of cancers that can be found in the stomach. From a Western perspective, in terms of ESD, we know that ESD takes a high level of technical skill. It is challenging because of the lower volume of gastric cancer. Often in the West, ESD training is started in the rectum. It is difficult to train as there's less expertise in the Western world as there is in Asia, although that is now changing and we do see much more expertise. And most large training programs do tend to have ESD procedures being performed. The procedure time is much longer than performing EMR, and we do have a lack of reimbursement in Western countries for ESD, which makes this difficult. Training in ESD can also be successfully achieved in the West. It is very useful to initially gain proficiency in EMR and closure and hemostasis to really understand the fundamentals. Then knowledge of ESD theory can be acquired through attending different courses, and it is very important to observe experts performing ESD, generally at least 20 cases, as well as training in animal models, both explant and live models, to gain experience with controlling bleeding and hemostasis. Initially, it is preferable to start with small lesions in either the antrum or the rectum, approximately 20 cases or so, and then move on to the esophagus, and then the more difficult areas of the proximal stomach or the colon. The first 10 cases should generally be performed under expert supervision. Hybrid ESD is a great technique for those getting started in ESD. It can also be very useful for lesions that are very fibrotic in the center. This technique involves performing a circumferential incision around the lesion and dissecting it down to a pedicle. The lesion can then be removed en bloc using a snare. Expert proctoring is essential to learning how to perform ESD in human patients safely. Video-based proctoring can be used both for animal training and human training. One study looked at video recording of the procedures in animal models with written feedback from a proctor mentor. And this was very useful in animal training to endoscopists who were able to perform a large 3-centimeter ESD in 30 minutes within 23 to 25 procedures performed in animals. Live video proctoring can also be used for human cases as well. In summary, ESD is a powerful technique allowing for en bloc resection of lesions of any size. It does have the potential to prevent surgery and cure early cancers of the GI tract. There are significant challenges to training. However, there are now increasing opportunities to train, and technology has increased the training opportunities. ESD now should be adopted by expert endoscopists all over the world. Thank you.